Right, right.
Super.
Super.
Well, look,
Well,
thanks
look,
very
thanks
much,
very
and
much,
thanks
and
very
thanks
much
very much
for
for
inviting
inviting
me
me
to this
to this
meeting. I'm
meeting.
sorry
I'm
I'm
sorry I'm
only here
only here
virtually,
virtually, but
I think
I think
Andrew's
Andrew's
laid
laid
out
out
some of the
some of the
key
key
issues
issues
that I
that
would
I would
like to
like to
spend a bit of
spend a bit of
time
time
on
on
in my
in my
talk as
talk as
well.
well.
And
And
I'd like
I'd
to
like to
start really
start
with
really
the
with the
crisis
crisis
in
in
healthcare and
healthcare and
healthcare
healthcare
delivery that I
delivery that
think
I
we're
think we're
seeing in
seeing in
all,
all,
certainly all
certainly all
Western
Western
countries
countries
at the
at the
moment.
moment.
And it's
And it's
particularly
particularly
prevalent
prevalent
in
in
countries with
countries with
single-payer
single-payer
healthcare
healthcare
systems like
systems
the
like the
UK
UK
and
and
indeed many
indeed many
European
European
countries.
countries.
And that
And
is
that
that
is that
there
there
has been
has been
this
this
dramatic
dramatic
shift in
shift in
demography as
demography as
people
people
age
age
more.
more.
And
And
those
those
numbers
numbers
Andrew has
Andrew
showed you, they're
showed you, they're
really
really
quite
quite
striking. And
striking.
it's clear
It's
that
clear that
medical
medical
science has
science
done a
has done a
lot to
lot to
extend
extend
life
life
expectancy.
expectancy.
But the
But the
problem
problem
is that
is
we
that we
haven't
haven't
really been
really
very
been very
effective
effective
at
at
extending
extending
healthy
healthy
life
life
expectancy in the
expectancy
way
in the
that
way
we
that
would
we
have
would
liked to
like to
do.
do.
So
So
a
a
large
large
number
number
of
of
healthcare
healthcare
systems are
systems are
now
now
collapsing
collapsing
under the
under the
pressure
pressure
of a
of a
large
large
number
number
of
of
elderly
elderly
people,
people,
some of them
some of
very
them very
frail,
frail,
many of them
many of
with
them with
multiple
multiple
different
different
chronic
chronic
diseases.
diseases.
And
And
once you're
once
over
you're
the
over
age
the
of
age of
70, you
70,
don't
you
just
don't
have
just have
one
one
chronic
chronic
disease, you
disease, you
often have
often
two,
have
three,
two,
or
three, or
four
four
chronic
chronic
diseases.
diseases.
And so the healthcare system really is finding it very hard to fund and manage that population of people. And it's changed the way all healthcare systems that I know of are working. The big burdens of disease in that age group are the common chronic diseases, heart disease, stroke and cerebrovascular disease, diabetes, the common cancers, obesity, which is a risk factor for a lot of diseases, orthopedic conditions, again, precipitated often by obesity. Those are the big factors that actually are collapsing our healthcare systems around us. And with that comes a massive cost to society. And that cost to society, we have focused largely in the past on what it costs to run a healthcare system. And of course, in the UK, we've got a variety of tools that we use to try and constrain expenditure within a healthcare system. But the big coefficient that many of these uh, gating processes have missed is that the challenge of these chronic diseases in middle and late age is that we're losing massive economic firepower by having large numbers of people out of the workforce. Productivity is flat or falling in many countries. GDP growth, of course, is constrained. And in places like the UK, the dominant driver for that turns out to be this great burden of ill health that we see in people over the age of 50. And interestingly, that the healthcare system that we built up so successfully since 1945, essentially, the growth of biomedicine and healthcare that we've seen in all developed economies has largely been focused on acute hospitals, doctors who look after people with symptoms or in the late stages of disease, and then community-based practice, which in the UK and elsewhere is based around primary care, who are now overwhelmed by the frail elderly population and can't really provide the kind of community care that we need. So when you add all that up, it means really big trouble. And it's become clear that the role of economists in trying to think our way through this is a really important piece of the puzzle, because the consequences of this are a real economic challenge to most countries, and we need to address it to be able to correct that particular problem. So if I can just go back and spend a little bit of time telling you how we kind of got to this place and what we might do about it, it's first important for you to know and remember that many of the diseases that I've described, these chronic diseases, have their origins in early life. Some of them begin in childhood, a lot of them begin in childhood, but many of them also are evident in people in their 20s and 30s and 40s. But in those age groups, they're often asymptomatic. So there's a disease process which is going on that in the end will end up with those clinical syndromes we know as a heart attack or a stroke or renal failure or all these major chronic diseases, chronic obstructive airways disease, all the big chronic diseases. But in the first 60, 70% of their natural history, they are asymptomatic. And you're just accumulating trouble that will actually precipitate itself with an acute event. And that's where these common risk factors become quite important. So we know that there is a sort of milieu of risk factors that we all sit in through most of our lives that are associated with bad diets, obesity, raised cholesterol, raised blood pressure. Those things all together contribute to a situation where you then end up with end stage events like a heart attack or a stroke or dementia. And most of those are due to the same risk factors. It's just a question of what gets you first. But it's the same common set of risk factors. So I think it's important to remember that the healthcare and medical profession has focused on the last 20% of natural history and has largely ignored the earlier bits, with the exception, of course, of one big example, which is the use of vaccines to prevent downstream infections and sequelae of those infections. So the vaccine guys have obviously historically treated people who are asymptomatic and not infected in the hope of preventing things occurring in later life. And so that's been, one of the great successes of prevention over time has been the use of vaccines to prevent infectious diseases. So we've now got a situation where the big burden of diseases you want to prevent are these chronic diseases of middle and late age. And what's really interesting is that we know that if you could get at the underlying risk factors and the determinants of driving those diseases when people are asymptomatic, then you can dramatically flatten all the downstream morbidity. And the best example of this, of course, is the efforts that went on to control serum cholesterol and blood pressure, based largely on therapeutics that were discovered in the 70s and the 80s. And those agents, now all generic and all costing substantially less than a penny a tablet, have had a dramatic effect on the downstream mortality and morbidity that we get from cardiovascular disease. So many Western countries have seen a fall of almost 70% in cardiovascular mortality since the 1960s to now. And that has been largely driven by those interventions that reduce the risk factors, treat people who have got the exposure to the risk factors, but not necessarily symptoms, and flatten that mortality and morbidity curve. So we have some really spectacular examples of how early intervention and prevention has been highly effective. But the real challenge, of course, has emerged as to how do you keep people taking the tablets, and how do you get people on the tablets, and how do you keep them compliant with those therapies. So since the discovery of those early therapeutics that you could use to treat hypertension, high cholesterol, better management of diabetes, another one. So there are many examples of things where we've worked quite hard to reduce the available risk factors. In the last 10 to 15 years, we've had a real explosion in the development and the availability of tools to actually do prevention, even though we don't do it. And just to be crystal clear, no healthcare system in the world does this very well. But that's despite the fact that we've got a lot of tools that you can use for that. Now, one of the issues, of course, is everybody says, well, we know what the answer to obesity is. You just got to stop eating and join Weight Watchers and reduce your intake. Unfortunately, we now know that there's quite a wide range of genetic liabilities to obesity. And if you're at the extreme end of those liabilities, it doesn't matter how much you try and stop eating, you will still get obese. So behavioral interventions are not to be dismissed, but they haven't proved to be the answer that we thought they would be for the prevention agenda. And so we've actually now developed a whole set of new tools, which we think will be hugely helpful in developing an agenda where we focus not on late-stage disease, we focus on asymptomatic people much earlier. And of course, this has become the mantra of many healthcare systems. none of which, I have to say, including the NHS, have made any effort to actually truly introduce a prevention system at scale. And the first thing that we've got now that we didn't have before is we've got a set of diagnostic tools that can be used to make much better prediction about what diseases you're likely to get, even at a stage when you're quite early on and don't have any symptoms and may only have a few environmental exposures. And there's a whole range of information that you get from healthcare records, that you get from biomarkers like serum cholesterol, LDL cholesterol, HDL cholesterol, blood pressure, BMI, or the tendency for obesity, as well as things like genetics and the use of AI to integrate all that information to actually give you much better predictive tools to identify people at risk of disease. And the reason that's important is that if you're going to do prevention early, you might actually have some people in whom you're trying to prevent these diseases, the onset of these diseases, over a 20 or 30-year time frame. And if you're going to do that, you probably have to be pretty sure that they're on a trajectory that will give them trouble in the end. And that's why these predictive analytics are actually quite powerful. And amongst one of the most powerful tools there is the use of genetics, which of course you can use. Your genetics is the same when you're born as when you die. So, you could do genetic predictive analytics in newborn babies if you wanted to, or you could do it at any stage in life, and get fairly robust estimates of risk to a wide range of diseases. Almost all of the major common diseases have some element of genetic risk. It's almost never more than 50%. It's usually considerably less than that, but it adds up with the other things to an important part of the formula. And then the final thing, in addition to the diagnostics, where you can actually identify who you'd want to prevent what diseases in, are this fantastic array of new therapeutics, which are now appearing at scale to try and manage this problem in middle age or even early middle age. And they include the existing generic medicines for blood pressure and for cholesterol management, but also these interesting new drugs, which are called siRNAs, which are injectable medicines that will dramatically reduce your risk of elevated cholesterol and, as a result, cardiovascular disease. And it's a single injection, and they last up to a year. So in terms of compliance, these are terrific tools because basically it means one injection, you can prevent cardiovascular disease for a year. And the same applies to the one which is now being developed for hypertension, the angiotensinogen siRNA. So you could, in theory, have a single injection that could control both blood pressure and cholesterol for a year, and then you come back a year later, like it was a flu vaccine, and you get it every year and you're protected. There's been an array of exciting new vaccines for the elderly, which are able to control many of the common respiratory pathogens that cause illness and often cause death in the elderly, but also cause disability and illness at scale. And that includes, influenza vaccines, COVID vaccines, but also vaccines for things like RSV, as well as vaccines for things like shingles, which appears to have some beneficial effects in terms of preventing diseases like Alzheimer's disease. So there's quite a broad set of those opportunities. And then, of course, and Andrew mentioned this, the advent of the GLP-1 drugs, which have been used for a long time at lower doses for the treatment of diabetic patients, now look to have a miraculous set of they've been developed by some companies as obesity drugs. They're not really obesity drugs. They prevent a whole range of different disorders and look to be very potent and effective drugs for reducing risk of all the diseases I've talked about. They're currently injectable. They won't be injectable forever. They're likely to become very rapidly orals. So then the final thing, given the fact we've got diagnostics and we've got therapeutics that you could use, is how do you deliver this to a population? And what you don't do is use an existing healthcare system, because hospitals and doctors are they're the incumbent party here who don't really want to do prevention. And hospitals are really designed for sick people, so you can't do prevention there. Primary care hasn't really worked, but you do need a channel to get these things to people. And of course, there are possibilities there about using digital channels much more effectively because most of the diagnostic tests can be done on a one-time visit, and then you can pursue those. So there, I think thinking about all those things together, the diagnostic, therapeutics, and the delivery channel could provide real opportunities at a relatively low cost to provide a much more directed prevention strategy. So those are the things we need if we're going to get this to work. But we also need healthcare systems to think quite hard about changing what they do. And that, of course, is the hardest thing. So politicians love talking about prevention. No politician I know has ever done anything about improving the prevention arena. And that's in every country that I'm in contact with in the developed economies or in the LMIC. So there does need to be a commitment to get this to work. Obviously, you need to generate some data, but you don't need a lot of data because we already know the effectiveness of lowering cholesterol. And just to give you a real shocker, I run a large cohort in the UK, which now has about 2.5 million people over the age of 18 enrolled. And we've just looked at the health of that population recently. Andrew Scott's doing a detailed dive about the state of the nation's health. But just to give you a sense about where we are in the UK, 52% of people in that cohort, and these are normal asymptomatic people off the street, have got a cholesterol that's too high and needs to be treated. That's half the population. 26% have a BMI more than 30. That's obese, and I would say morbidly obese. 25% of the people have uncontrolled blood pressure, which could kill them at any moment. And about 30% of people age 18 to 30 have got moderate to severe mental illness. So that's the reason economies are not growing. That's the reason GDP is flat. That's the reason productivity is flat. Unless we fix that problem, we're not going to get out of this hole, and we're not going to fix it unless we pivot our healthcare systems to a much more prevention-oriented strategy. Anyway, look, that's it for me. I'm happy to take questions if we have time.
Fast on so that you can actually hear the question, but
John, I'm not sure if you can see me, so I'll stand up. I'm Shushi Singh from the OECD. Thank you so much for those fascinating thoughts and remarks. I totally empathize with the UK system. I'm from London, and been dealing with sorting out long-term care for my father in the last couple of years. But anyhow, apart from that, I think both you and Andrew have very nicely expressed all the different challenges in terms of prevention and healthy aging. I think one really interesting part of the puzzle here is that life expectancy actually changes enormously among men and women. So women tend to live a lot longer. And that raises a lot of different questions in terms of policy, intervention, and perhaps even lessons for how women behave and what is it about their behavior that might could be used and be for men and changing their behavior. So the question was that the sort of the toolkit that you've been working on. I mean, have you thought about that in terms of what lessons to be learned, or should a universal toolkit in terms of diagnosis or prevention or treatment be the same as men and women? Thank you.
sorry, we can't actually hear you. Might have to restart in a second. Yeah.
Okay. Hey, how's that? Can you hear that? I'm on at my end. How about that? Can you hear that?
Perfect.
Great. I'll just keep talking. Wave your hands if you can't hear me. Yeah, so look, I totally agree. There's always been this differential between men and women. It's a really interesting observation. Women do better, both in terms of morbidity, but also mortality. They have one big advantage, and it's called estrogen. And there is something about the biology of women which actually protects them from some of the big cardiovascular events. And it's one of the reasons why most of the cardiovascular events in women occur post-menopause, because that's when their hormonal protection seems to disappear. They, of course, carry other risk factors in life. There's a difference between men and women. I think one of the things that we're going to see quite profoundly in the not too distant future is that there is definitely something happening with men, and men at an early age. And the Americans have the best data on this. But as you know, there's this concept of the left behind men in America who, between the age of 20 and 35, seem to largely drop out of society. Suicide rates are 4 times in that population what they are in women. It's a really, and they will be accumulating all kinds of health issues over that time frame. So obviously, this has to be individualized at some level, but we would be well aware of the differences between men and women. Need to think about it hard.
Thanks. I think we'll take one more at least from.
So many common chronic diseases, and trying to find the root causes. What I'm really concerned about is that we've looked at one part of the equation, that is that health leads to better economic outcomes. My work basically focuses on social determinants of health, and really, at least as much as health influences economic factors, I think the evidence would suggest that economic factors, the nature of work, the nature of education, the kinds of inequalities that we see very early on, are determinants of health. And so it's a two-way causal sort of pathway. And if we think about how to improve health, then the major determinants may well be sitting in our realm and not in healthcare center realm. So I wonder if we could integrate that thinking somewhat.
Yeah, so I mean, I don't think there's any doubt that the social inequalities are a major driver of health or ill health, and that's been documented a million times. And I think it's it's a societal responsibility to try and fix that. It's unhelpful that we don't really understand the mechanisms for that. Some of them are rather obvious, and that is people in low socioeconomic groups tend not to access healthcare in the way that those in the middle classes and higher socioeconomic groups do. So that's an obvious reason. There have been various stories about underlying biological effects that drive that particular difference. But the real problem is what to do about it. And of course, you can improve it by improving living conditions, improving employment conditions, improving education. Nobody would disagree with any of those things. And they're all things that I think are on the agenda of various governments. But you can actually have quite a profound impact also by intervening at a medical level. Because in the end, the health problems are being driven by biological processes that we can now stop and intervene with. And these interventions are incredibly cheap. They're really easy to deliver. And the health system, as we know it now, simply doesn't do it. And it particularly doesn't do it for poor people. And I think that is one of the really big problems, is that they carry the burden of this disease because the health system has failed to use known interventions that would actually have quite a dramatic impact on their health. So that, I think, needs to be very much part of the formula. And perhaps the best example of this is when the GLP-1 drugs became clear that they had remarkable effects for preventing disease. The NHS decided that they weren't going to distribute them through the NHS, and as a result, they all get bought through private practitioners in the UK. And guess who doesn't get them? It's the poor people. So we have systematic problems about trying to solve the inequalities of health. So I couldn't agree with you more, but we're not going about it in a very smart way.
And I'm under a bit of pressure to move on, but thank you so much, John, for your intervention.
Yeah, great. Take care.